Assalamu alaikum dear doctors. In this video you will hear a marmar. First we will hear the video, then I will discuss in details. First, what we hear? We hear a pansystolic murmur. We know that pansystolic murmur is maximum intensity on the left lower sternal edge, LLSE. And it is propagated all over the pericardium. It is not radiated. So this murmur we are find in left lower sternal edge. And we know that pansystolic murmur we find the mnemonic is easy to remember, MTB. MTB, that is mitral regurgitation, tricuspid regurgitations and ventricular septal defect. Among them I will discuss the ventricular septal defect, VSD, in this video. In VSD ventricular septal defect, the special phases we can find may be associated with Down syndrome, plus minus cyanosis, plus minus clubbing, signs of heart failure and plethoric phase. So this can be found. In VSD, the pulse may be rapid, neck is normal, and inspection we find usually no scar. If scar present, then that is a median sternotomy scar only if operated. Apex, we find hyperactive apex displaced out and down. There is plus minus parasternal hip, plus minus palpable second heart sound and thrill on left lower sternal edge. And murmur. Murmur number 1 we find pansystolic murmur with maximum intensity on the left lower sternal edge and propagated all over the pericardium, not radiated. Number 2 may be associated with soft diastolic murmur of relative mitral stenosis. Number 3, if operated, you may hear diastolic flow murmur at the apex due to overflow through the mitral valve, or pansystolic murmur at apex radiated to axilla, that is residual MR. What investigation we find? Investigation number 1 is echo, that is diagnostic, confirm the size of the defect, assess pulmonary hypertension, then the follow-up. Number 2, chest X-ray, small VSD usually normal, but in case of large VSD, cardiomegaly, left ventricular hypertrophy with lung plethora. Number 3, ECG we find if large VSD, left ventricular hypertrophy, then biventricular hypertrophy. Treatment. First, ask about the compliance to treatment. Medical treatment, number 1, if hemodynamically not significant, then multidisciplinary team and cardiologist follow up, echo, and 80% will close spontaneously. Then if the patient is hemodynamically significant, then I will involve the multidisciplinary team and cardiologist for medical treatment for heart failure, nutritional support, diuretic furosemide, AC inhibitor, captopril, fluid restrictions and surgery. Indication for surgery in VSD patients are number 1, failure to thrive, number 2, failure of the medical treatment, and number 3, large VSD if Swiss cheese appearance, pulmonary systolic blood flow more than 2 in 1. Number A is small VSD just observed, close follow-up. The number B, moderate VSD, what we give? Diuretics, AC inhibitor, then surgery at 2 to 5 years. And in case of large VSD, 3 to 6 M, except in Down syndrome at 3 months, we do operation. And if large VSD but the child not fit for operation, we'll do pulmonary artery bending. Next question is that why Down syndrome prone to pulmonary hypertension? Because of nature of the disease and nature of the vessels in Down syndrome more prone to early pulmonary hypertension. Example of the palliative surgery. These are pulmonary artery bending, then BT shunt, that is aorta and subclavian. Number 3 is atrial septostomy because of TGA, position of great arteries for mixing. So this is all about VSD. Please do subscribe and share MRCPCH with Dr. Emma Choudhury. Thank you.